Today we are going to talk about a drug that has been used and has been studied in the COVID-19's severe and critical cases. So the drug name is Tocilizumab, and let us start discussing how does it work. So, Walaikum Assalam, and let us start our discussion. We're talking about the Tocilizumab. So I'm going to share my screen and we would look at it. So first of all, this is Drbeen.com. Most of our videos that have been going on the YouTube are posted here because some of the videos are taken down by the YouTube. Okay, so let's start. Thank you very much. Welcome everyone. Let's start our discussion. Very important discussion, a drug that is used in the severe and critical settings of the COVID-19. So the drug is Tocilizumab, and the drug is an IL6 receptor blocker. So keep in mind, it is an IL6 receptor blocker, not an IL6 blocker itself. So let's start. You are very welcome, Ari. So first of all, the drug itself is an immunosuppressant. And we would see that shortly, that why do we call it immunosuppressant? It is going to modulate the immune system responses towards a more balanced response or a little less intense response. And the reason for that is that it is seen that interleukin 6 causes such an imbalance in the immune system that the chronicity of the immune system, that means longevity of the immune system function for a longer time, becomes enhanced. So people develop chronic diseases, for example, rheumatoid arthritis, and this interleukin 6 receptor blocker can help bring the immune system back in balance and reduce the severity of the disease. So that is what we're going to see. This drug is approved for rheumatoid arthritis and for systemic juvenile idiopathic arthritis. That is an early childhood disease. So with this, the drug itself is a humanized monoclonal antibody. And we have discussed that in our past. We have looked at how these monoclonal antibodies are produced. Remember, just for a quick review, that what we do is we take the antigen against which we want to make the antibody. In this case, for example, we will take the receptor, IL6 receptor. So let's say this is an IL6 receptor that we took from our cells. We will inject that receptor, we'll put that receptor, let's say, in a mouse. So here is a mouse. And then as the mouse has that as an antigen, then what would happen is that in this mouse, we will have antibodies produced that will be against this receptor shape. So mouse will produce antibodies. These antibodies, because this receptor, let's say this is IL6 receptor, which is taken from our cells. This receptor, when it goes into the mouse's immune system takes that as a foreign agent or an antigen and produces the antibodies against that. We talked about it in the past. Those antibodies can now bind with this receptor. Just like nowadays, we are trying to find neutralizing antibodies and binding antibodies that can bind with the COVID-19 S proteins. So once we have that immunoglobulin produced or antibody produced, then what we do is we further do engineering on that, and we only take the binding sites. So these are the binding sites of the antibody. We take these binding sites, we replace the remaining part of the proteins with a human antibody, and that is called a humanized antibody. If it was the mouse antibody, then we would call it chimeric antibody, and then we take the binding sites from the mouse, and then we replace the remaining part from our own antibodies. Why do we do that? This way, when that antibody is injected into our body, then our immune system will not react negatively to it. Immune system would take that antibody as its own antibody and will not cause a reaction. So with this, the antibody that is interleukin 6 receptor blocker, or tocilizumab, is a humanized monoclonal antibody. So here the red parts are the one that came from the mouse, which are against the IL6 receptor. The blue parts are the one that came from a human being or are more like human being antibodies. So I hope that is clear. Now back here, before we go into the mechanism of action, let's just very quickly look at the status of the drug itself, the tocilizumab. Number one, there are no studies available for the fetus outcome. So we do not know that if it is given to a pregnant woman, what will happen to the child, what damage. So we do not know that. Number two, animal studies on pregnant animals have shown that in high doses, tocilizumab can cause sudden spontaneous abortions. Then there is also no knowledge yet of the tocilizumab's lactation, meaning secretion in the milk, and the effect during the nursing. Remember, it is an immunosuppressant, so wherever it will go, it can cause the immune system cells responses to reduce, which might open up the system for infections, for example. So it is not known that a nursing mother would develop infections in the breast, or the child who is taking that milk will develop any immunosuppression. So not recommended for pregnant or nursing women. It is also contraindicated in patients with infections or latent, for example, latent tuberculosis or acute infection. So that kind of goes contrary to the discussion that we're going to do, and we are going to talk about the acute infection with COVID-19. And we would see that what is the basic mechanism, but long-term use of this drug can actually exacerbate infections. So somebody who has the acute infection, for example, pneumonia or something else, for them at that time, tocilizumab may not be that good. Now let's look at the adverse effects. So adverse effect over here, the one in the blue are the more common adverse effects that are seen. So for example, it can cause headache, upper respiratory tract infection. Remember, it is a immunosuppressant. So when it will cause immunosuppression, immune system will not respond correctly or not respond with the right intensity, and that would open up the system to infections. And respiratory system, as we can see, is a very fragile system. It is open to outside. We breathe in air all the time in the respiratory system. So it is always open to insults from the pathogens coming in. Now, if we reduce the immune system intensity and severity, or immune response is curtailed, then infections can happen. So 10% of the patient develop upper respiratory tract infection, and that is the most common side effect of tocilizumab. 5% of the patients develop high blood pressure. 5% of the patients develop high ALT levels. And this is important to know so that you're not mixing the ALT effect by this drug with the ALT effect with, let's say, tissue damage. And then increases the total cholesterol levels as well. Now, in the setting of COVID-19, it is not a drug that will be used for long term. For rheumatoid arthritis, for example, it is used for long term. So here it is not used for long term. So hopefully these effects can be tolerated because it would be only for some days. Then it causes nasopharyngitis. Again, immune system is down, so infections in the nasal area or pharynx area can occur. The things that I've written here in green are less common outcomes, and it can cause dizziness, it can cause mouth ulcers, it can cause gastritis, it can cause other kind of infections, or it doesn't cause them directly. It reduces the immune system, which allows the opportunity for the pathogens to develop. and then mild rashes can be observed. Rarely, and how rare? In 0.26% of the patients. That means about 1%, 1% in 400 people may develop GIT perforation. So their GIT, gastrointestinal tract, may develop holes in it. So GIT perforation after 6 months of use. So hopefully that is clear. These are the side effects. So now we know the contraindications. Now we know the side effects. So do not give it to pregnant women. Do not give it to people with latent tuberculosis. Do not give it in acute infections. And ironically, we're going to talk about giving this drug in acute infection, which is COVID-19. Okay, so ready to discuss how tocilizumab actually works. What is the mechanism of action? So number one, the drug, the interleukin-6 is produced by the genes that are present on chromosome number 7, short arm, P arm, and the region 2-1. So that is where the interleukin-6 genes are produced. Not tocilizumab, we're talking about interleukin-6 genes. So there is a question from James Kelly. I understand this for IL6, but ain't IL1 and 8 also pro-inflammatory? There are many interleukins that are pro-inflammatory. Almost all immune cells release interleukins or cytokines that promote their function. However, interleukin-6 has a unique role that which we will talk about, that it causes an imbalance in the immune system. And there are many other cytokines that can cause imbalance. For example, IL-1 is not known to cause an imbalance, or IL-8. But IL-6 is observed to have caused imbalance from the evidence that is collected. So then we try to suppress IL-6. There are many other ways to do that as well, but especially for cytokine storm-like situation, that is where it is actually approved as well for cytokine syndromes. So that means the IL-6 has a more potent effect in those areas. So now let's look at what does it do. Number one, when there is inflammation, when there is acute infection, for example, COVID-19 or other acute infection, interleukin-6 works on liver. Remember, we have talked about it in the past. It is released from various cells, and we'll look at that mechanism today. It is released from immune cells, for example, macrophages, or it is released when the tissue breaks down. The tissue breakdown patterns are released, which then are seen by the immune cells. They realize that there is some kind of a destruction going on, and they would then in turn start producing interleukin-6. Once the interleukin-6 is produced, interleukin-6 will go, for example, to liver, and in the liver, it will enhance the production of acute phase proteins. These are the proteins that are going to help in the inflammatory response. What are those proteins? I think that we all know C-reactive protein, CRP. Nowadays, CRP is very, very commonly measured in the severe and critical infections in the hospitals, because it is an indicator of how bad the inflammation is. So C-reactive protein is triggered by, it is released by the liver, triggered by interleukin-6. Then serum amyloid A, fibrinogen, haptoglobin, alpha-1 antichymotrypsin, and so on. These are acute phase proteins. These are the proteins that body made to start the fight. And these are triggered by interleukin-6. Another interesting thing that interleukin-6, and I think we have been talking about zinc for a long time, interleukin-6 acts on the liver cells and causes them to produce more or to express more zinc transporters, which causes them to process more zinc and release that in the blood, which results in hyperzincemia or increased levels of zinc. So in COVID-19 case, they may actually be useful, as we know that the zinc is useful. However, the zinc still needs to be able to go into the cell by some ionophore. Interleukin 6 does not help make ionophores throughout the body. It only acts on the liver to help produce zinc channels that allow more zinc to be processed and released in the blood. So zinc levels are increased by interleukin 6. Then iron levels are reduced. What it does is it reduces the iron absorption channels in the GIT. The result is that the patient in chronic inflammations cannot absorb iron, and that results. So there is a theory that the anemia in chronic inflammatory disease patients is because of interleukin 6 suppressing the iron absorption. So iron levels down, zinc levels up in the blood. Then it works on the bone marrow. So here there is a bone. It works on the bone marrow and causes the maturation of megakaryocytes. Megakaryocytes are big cells in the bone marrow from which, like small teardrops, platelets are pinched off from them. So megakaryocyte, mega means big. So these are big cells, and when they break down into smaller pieces, smaller little bags are formed from them. These small little bags are platelets. So when interleukin 6 acts on the bone marrow, it would cause maturation of megakaryocyte, which in turn would cause the platelets to be increased. So remember that increased platelet can be a good thing, but for example, if we connect it to COVID-19, increased platelet would result in more hypercoagulable state because platelets will be more available to create more thrombi, which would cause more embolism and thrombi in the blood vessels, causing the blood vessels to be occluded. So platelets are increased. Then here, and I'm going to explain this a little more in detail, on the immune system, this is what is more important. But let's just first see what kind of effect it does, and then we'll draw that map of the immune system that we draw every time. Number one, it works on cytotoxic T cells. Cytotoxic T cells, and it makes them differentiate. Differentiate means more copies of them are formed, and now there are lots of cytotoxic T cells, and they're going to start acting and fighting. So that is one. Then there are naive T cells, which we have talked about many times, and I'm going to draw that in 1 second. I just want to have the overall picture of the interleukin in front of us. The interleukin 6 acts on naive helper T cells, T4 cells, and it helps them in the presence of interleukin 21, I believe. In the presence of interleukin 21, it helps them mature into T helper 17. The naive T cells can become T helper 1 or T helper 2 or T helper 17 or T helper regulatory or Treg, depending upon what kind of interleukin you pour on their head. So we would draw that in 1 second. So the result of that is that when naive T cell under the influence of interleukin 6, I should have said interleukin 6 instead of 21 here. That is what we were actually talking about. So when the interleukin 6 is present and a naive T cell becomes mature, then it will become T17 cell, T helper 17 cell, Th17. These T helper 17 cells in turn cause neutrophils, which are part of our innate arm, to be increased in number. They help stimulate for the formation of neutrophils. Neutrophils, like macrophages, are the first responders to an infection. They are the ones who would cause so much of inflammation, and they would cause so much of chemotaxis of other systems, other cells to come in, and they would ramp up the inflammation so much. And if you are going to now increase the number of neutrophils, then the neutrophils' own function is increased, which is also causing inflammation, plus the whole army of the immune system would come over there as well. So that pathway of increased neutrophil goes or is triggered or enhanced by interleukin 6. So that is another damaging thing that it does. In Ideally, there is a balance of T helper 17 and T regulatory cells. T regulatory cells are anti-inflammatory and T helper 17 are pro-inflammatory. There is usually a balance between them. So when there is extra interleukin 6, that causes extra production of T helper 17. The balance is tipped towards pro-inflammation, and the poor T regulatory cell that are going to say, hey, we want to suppress inflammation, they themselves are suppressed. So T regulatory cells are usually activated with the tumor growth factor beta. So you can see that guy over here trying to tell the T helper cell to T regulatory cell to wake up and function, but that T regulatory cell is suppressed, or the production of that cell is suppressed because of interleukin 6. Interleukin 6 promotes the formation of more IL-17, T helper 17, and suppresses the formation of T regulatory cell. So that imbalance between the helper 17 and T regulatory, that imbalance is theorized as the reason for chronic inflammations and for one of the reasons for cytokine storms. And I think we have talked about that in the past as well, that how this whole cytokine storm comes together. So this is how the immune system cells. Then one more important one, very important one, and that is this guy, this area. Interleukin 6, number one, helps get more production of interleukin 21. Then 6 itself and 21, they both act on B cells. Remember, the B cells are the ones that produce antibodies, and they help them make more antibodies. So antibody production is increased. Again, for us, antibody production is a good thing, but again, all of these steps that you're seeing are eventually causing an increased level of inflammation. So with this, let's now just very quickly draw a holistic picture of how the immune system comes together under the influence of interleukin 6. So first, see here, how is the interleukin 6 produced? Macrophages produce that. I'll draw that in a second. Adipocytes are produce that. This is why folks who are obese, they have high C-reactive protein in them, because they have high levels of IL6 produced by the adipocytes. And then that would then cause, remember the acute phase protein from liver, that would produce more C-reactive proteins. Mesenchymal cells, they produce interleukin 6. Epithelial cells, this is important for us to know because our respiratory system is epithelial cells. And then fibroblasts produce interleukin 6 as well. And this is also important because we have so much or so many fibroblasts throughout our body, especially in our lungs as well. And when there is tissue damage, fibroblasts are under the blood vessels as well. So when there is tissue damage, fibroblasts become active, they start producing interleukin 6. So there are many cells that can produce interleukin 6, which in turn would cause so much inflammation that in some people it results in cytokine storms, which then we need to stop. So one way to stop that is by tocilizumab-like medicines that will go and block the receptors. Where are the receptors? Remember, the receptors are going to be here, let's say on T helper 4. Receptors are going to be on B cells. Receptors are going to be on cytotoxic T cells. So many cells have receptors on them for interleukin 6. So when these guys will produce interleukin 6, that interleukin 6 is going to go and work on the other cells, and those cells would then enhance the immune system. Good. So now let's put this whole thing together. And what are we talking about? We're talking about a drug that would block the receptor. So let's say if this is the receptor here, if I can magnify this, let's say this is the receptor for interleukin 6. And instead of interleukin 6 on it, if we bring in tocilizumab, what is that going to do? That is going to sit here and block this receptor from the function of the IL6. And that would cause the immune system dysregulation to become balanced. And that would cause the immune system's responses to become less. Remember, we talked about it that if you give the tocilizumab in a longer term, then there is infections that occur. That means immunosuppression occurs and the body is not able to handle infections. Again, in short term, in COVID-19 severe and critical patients, we actually want to reduce the inflammation. We want to reduce that for a few weeks, so it's not going to cause too much of a harm. But because of extra inflammation that is causing harm, we want to give IL6 receptor blockers to calm down the immune system, to bring the patient out of that situation where they are stuck and getting a lot of tissue damage. So now let's look at it, that this is the last part. So here is what would happen. Let's say we have the coronavirus that comes in to our body. What is this guy going to do? It is an angry guy and it is causing lots of destruction. It is going to cause two kinds of destructions. One, it goes into our cells. Let's say this is an epithelial cell in the respiratory system. It goes into the epithelial cell, and when it is replicating in that process, it causes stress on the cell and it might even rupture it. Remember, it's not necessary that under coronavirus, the cells rupture all the time. Coronaviruses can actually exit a cell without breaking it because they have an envelope on them. But if the quantity of coronaviruses is too much or the cell machinery is too much damaged, the cell would actually die as well. So the cell stress or cell death would occur, which would cause tissue damage patterns or the debris of the cell to be released. This debris is going to be picked up by macrophages. And they're going to say, oh God, there is some destruction going on. I am seeing things that I should not see. These are the proteins or the substances that should have been inside the cell, packed away from my eyes, but I can see them and I can eat them, and the macrophage will become active. That is one. Second is macrophage would come and eat this pathogen itself. So let's say this is another macrophage. It is eating this pathogen. And when it would eat that, we know how the phagocytosis occurs when the pathogen is inside the macrophage. So these are the pathogens. Macrophage would start releasing various cytokines. We talked about it. More importantly, these macrophages are going to connect with naive T cells and present the antigens, the pieces of the virus, to them. Remember, this is MHC2 molecule, MHC2 molecule. Macrophages are presenting antigens on it. This is a naive T cell. Naive T cell. Naive T cells do not know what are they going to do in their life. They are kind of children. So they get connected there. Once they are connected, what will happen is, in the presence of various interleukins, naive cell will find their purpose in their life. For example, if we have interleukin 4, if we pour on their head, the naive T cells, interleukin 4, then they mature in T helper 2 cells. T helper 2 cells will then cause B cells to become active. They release interleukin 4 and interleukin 5, and that would activate and class switch. The result is that the antibodies will be starting to form. So that's a good one. We want that response. This is called humoral response. We've talked about it many, many times. But important thing here is interleukin 4. When that is present, then that causes the B cells to become active, and interleukin 4 causes the naive cell to become T helper 2 cell. If we have, on the other hand, let's say interleukin 6, then we just talked about it. The naive T cell in the presence of interleukin 6 will become T helper 17 cell. That in turn would cause the neutrophils to become active. And neutrophil, I make them like this. They are wearing lots of glasses. So they usually have a nucleus which is 3-lobed or 5-lobed. So when you look at them under a microscope, they look like they're wearing glasses and they have 5 eyes. So acoustic theory says there is a prior video about reinfection. Yes, we've talked about reinfection. We've talked about the cytokine storm. I'm reviewing that here. So the neutrophils are now going to be active. Now, what do neutrophils do? Neutrophil go to the site of infection. For example, the infection was here. So now more neutrophil that are produced, they will be here, and they are also going to start fighting here. They would release chemotactic factors, which would bring other cells to this place, and neutrophil would start actively destroying the pathogen as well. In that process, the cells will be destroyed as well. Please remember that the pus that is generated in the infected area, majority of the cells in that pus are neutrophils. So same is the problem with the COVID-19. The pus and the debris that is generated in the lungs because of the active infection and the fight with that infection, a majority of the cells in there are macrophages and neutrophils. And that neutrophil is activated by this path here. And this path has IL6. So if we can block IL6 or naive T cell by putting an IL6 receptor blocker like tocilizumab, then we can reduce this pathway of activity, which would then reduce the inflammation. Okay, so what else naive cell can become? A naive cell can become, if you pour interleukin 12 on it, then it can become a T helper 1 cell, which would then in turn cause T helper 8 cells to become active, and that is the cytotoxic response we have talked in the past. And the cytotoxic response is where this cell, the T helper 8 cell, will connect with an infected cell. So let's say this is the infected cell, and this cell has lots of coronaviruses in it or other viruses. T helper cell is going to come near that T helper 8 cell or cytotoxic cell. It is going to create holes in this cell by throwing proteins on it, which are called perforins. From the name, they call perforations. They cause perforations. Perforins are released that cause holes in the cell, and then another protein is thrown in the cell that is called granzyme. I remember that as grenades, hand grenades. So granzymes are thrown in to the cell by this T helper 8 cell. Granzymes, when they reach in the cell, they tell the cell to kill itself. They cause the cell to suicide. So the sick cells or virus-infected cells are killed by T helper cells, and this is what is called cytotoxic activity. Remember, interleukin 6 also causes T helper cell to differentiate as well. Over here, we talked about it, that T helper 8 cells differentiation is also done by interleukin 6, which causes them to cause a lots of destruction. And absolutely, somebody commented that this function is called apoptosis. Absolutely. So this encouraging a cell to kill itself is called apoptosis. So under interleukin 6, not only neutrophils are more in number, which are going to cause more damage, not only B cells are active, which are going to produce a lot of antibodies, which in turn are going to clear the virus, but antibodies are also going to cause more inflammation, because when they would connect with the other cells and they would activate the complement system, there is another enhancement of the immune system. Then interleukin 6 is working on T helper cells as well and differentiating them and increasing their function as well. So that is also pro-inflammatory. Now we were talking about the naive cell. Naive cell then, under the tumor growth factor beta plus, I believe, interleukin 21, under that influence, it creates T helper T reg cells, T regulatory cells. These T regulatory cells are nice cells. They are our friend cells. What they do is they normally work in balance with the T helper 17. T helper 17 here, they are the monsters who say, you know what, I want more inflammation. And they can be good as well. When we need inflammation, they're there. But when they go out of their way and cause too much inflammation, that causes damage. So normally there is a balance between these two guys, T helper 17 and T regulatory. Unfortunately, under the influence of interleukin 6, T regulatory production is reduced and T helper 17 production is increased. That is also a pro-inflammatory balance, which then results into lots of inflammation. So if you think about it now, wherever we have interleukin 6 receptors, for example here, for example on B cells, for example on T helper 8 cells, everywhere there is a increased result of increased inflammation. So this is where interleukin tocilizumab comes in and helps. What does it do? It would cover all the receptors for interleukin 6, not all the receptors, a majority of the receptors, or whatever is the therapeutic dose and whatever is the intent. Once they are covered, interleukin 6 function will reduce, inflammation will calm down, and the system damage that is occurring to the patient would reduce. So Siddhartha is saying, what about interferon gamma feedback from the T helper cell? So yes, so what happens is, we know that T helper cell in response would send interferon gamma, which would then cause the macrophage activation, which would also enhance the immune system. We are aware that that happens. Here the question is not that. So IL6 is not really trying to suppress interferon gamma axis. IL6 itself is an axis. And that is what we are looking at, that how blocking the IL6 would reduce and calm down the overall activity of the immune system. So this is why this drug is important and has been tried in severe and critical and ventilating patient drug. It is not a drug that is given before that, although it is used for rheumatoid arthritis, but not in the COVID-19, it is in ICUs. So I wanted to show you a study. So that is the last topic, and then we are done for today. Here is the, let me see if I can find it. Here. So I would put those links out there. This is the link about tocilizumab. This is a very good link where they talk about interleukin 6. This is, if you were curious at what does chromosome 7p21 mean, then that decoding of the chromosome location, I just thought that was interesting. This is a function of interleukin 6. We have done the past as well when we talked about cytokine storm. T helper 17 cells. These are the cells that we just talked about, that we don't want them to be dysregulated or be in greater balance. We just talked about neutrophil. If you look here, the neutrophil nucleus is multi-lobed, and to me that looks like, see here, to me these cells look like they're wearing glasses, but they have more than two eyes, so they have those glasses. So here is a study. This study is the result. This result that we are seeing is the phase 2 trial on COVID-19 patients. And if you see here, patients who were on ventilators or in ICU and were given tocilizumab in 200 milligram dose or 400 milligram dose. So here, this column is, this first column is that patient who were not given, sorry about that. So the patients who were not given tocilizumab and they were just given placebo. And then here the tocilizumab was given in 200 milligram, here it was given in 400 milligram. And let's look at the results. Patients who died or on a ventilator, placebo 55%, tocilizumab 200 milligram, they were 46%. So if you see, there is a downward trend, and 400 milligram 32%. Patient who died, 12% in the study, the one who are, sorry, not 12%, 27% who were on the placebo, 36% who were on 200 milligram, and then 23% who were on 400 milligrams. So here, 200 milligram actually caused or did not help enough. It actually, there was a higher trend towards death. Then the patient on a ventilator, 27% patient ended up on ventilator. The patients who were given tocilizumab, 10% ended up on a ventilator with the smaller dose. Patients who were given larger dose, 9%. So there is a significant difference in the patient who ended up on ventilator. Then clinical improvement. Here 41% patients had the improvement. Here 51% had the improvement. Here 59%. Off the oxygen, 41% became off the oxygen, that is placebo. 43% became off the oxygen, and then 58%. Discharged, 41%, 39% a smaller number, 53% a greater number. So the way they interpreted this was that the trends were more towards better outcomes compared to placebo. But as you can see that there are some numbers that are not entirely as good. Because of that, the discussion and the trials and data collection is still continuing. Now, I do not know how to read French, although I had done French when I was in my 12th grade. But that is just this much, that vous êtes parlez français. So that is all I remember. So here, this is a study that came out from France. I have left it here for anyone who can read French and interpret that. They can look at it as well. So this is where we are. Acoustic theory is saying that, wow, you really do idealize Bill Gates. I hope that is not for me. All right, so this seems to be a separate discussion going on. I hope that this is clear. For the tocilizumab, reduces so this is a comment on my video in which I talked about race, and I explained that black folks are a little more at disadvantage because of many factors, and I had discussed those factors. Many of you were part of that video as well. So somebody left a comment there that you are causing treason against we the people, you should be sent to Gitmo. And I did not know what to say. Anyways, thank you very much for your time today. Thank you for joining. Please let me know what would you like to discuss tomorrow, and we will go from there. For today, thank you. Please like, subscribe, and share. Bye-bye.